Critline training series for the hospital setting. Volume management of the critically ill patient receiving renal replacement therapy with data from the Critline monitor. This program has been developed by the Fresenius Medical Care Renal Therapies Group. It is intended to provide pertinent data to assist healthcare professionals in forming their own conclusions and making informed decisions. It is not intended to replace the judgment or experience of the attending physician or other medical professionals. The treatment prescription is the sole responsibility of the attending physician. Let's review the objectives of the training session. At the end of this presentation, you will have a better understanding of the goals and key factors associated with volume management of the critically ill patient undergoing renal replacement therapy. We will review treatment options available in the acute setting where Critline can be utilized, and you will understand the data provided by the Critline and its role in the acute setting. Let's take a moment and review volume management outcome goals. Perhaps one of the most difficult things to do as caregivers is to manage volume in our patients. Making an accurate assessment of the intravascular volume status and volume responsiveness is essential in treatment of the critically ill patient undergoing renal replacement therapy. Finding and maintaining a hemodynamic stability can be increasingly difficult as organ failure begins. Finding a state of euvolemia or having appropriate hydration specific to each patient as well as comorbidities is equally important. Let's take a moment and discuss euvolemia. Euvolemia is characterized by an absence of clinic signs of dehydration, the presence of hemodynamic stability, and the absence of volume overload. Patients with acute renal failure can show evidence of low, normal, and excess extracellular volume depending on causation and accompanying conditions and comorbidities. When considering optimized blood volume, it is important to review when maintaining or decreasing blood volume is the best course of treatment. In many circumstances, patients in acute renal failure may not be carrying excess fluid and may still output a significant amount of urine. In such cases, it is important to maintain their current blood volume to protect blood flow to their high-flow organs, such as the kidneys and liver. This blood volume maintenance may also help restore renal perfusion. And for those patients in acute renal failure that may be carrying excess fluid, it is equally important to decrease blood volume to protect organs that are very sensitive to fluid overload. The heart and lungs are highly sensitive to fluid congestion. As the goal of ultrafiltration is to recruit fluid from the intracellular, extracellular, and vascular compartment, as vascular volume decreases, the heart and lungs will decongest. When we consider the relationship between hemodynamic stability and blood volume, it is important that we have a thorough understanding of hemodynamic instability and its impact. Hemodynamic instability causes a mismatch between oxygen delivery and demand. This is often a major contributive factor in organ failure. Let's take a moment and review two important components in obtaining hemodynamic stability in the critically ill patient: vascular pressure and oxygen saturation. Vascular pressure, which is dictated by the amount of volume in the circulatory system, is necessary to supply blood to the high-flow organs such as the kidneys and liver. Preserving circulatory volume ensures there is perfusion of the kidneys to allow for glomerular capillary pressure, which is necessary for adequate filtration of toxins. Although the kidneys are sophisticated enough to work through varying pressure variances, which is known as the renal autoregulation process, if vascular pressure is severely decreased, this autoregulation process is interrupted, causing impaired renal function. Oxygen is transported to various organs throughout the body via hemoglobin. High extract organs, such as the heart and brain, need adequate oxygenation at all times to maintain function. The heart to maintain its circulatory capability to carry enough blood volume throughout the body, and the brain to wash out metabolic products to maintain consciousness and carry out critical functions. Thus, maintaining oxygen supply to meet organ demand is critical for organ survivability. For patients in renal failure, decreasing the blood volume to increase hemoglobin concentration is essential. When we take a deeper look at the essentials of circulatory physiology, it becomes even more obvious that certain organs require maximum cardiac output, blood flow, and oxygenation. The heart and brain are high extract organs requiring more oxygen per organ weight, while the liver and kidneys are high flow organs which require more blood flow or volume. Earlier on in this presentation, we discussed euvolemia. Now, let's take a moment and review the implications of acute kidney failure and the loss of the ability to regulate fluid balance. In the critically ill patient suffering from episodes of hypovolemia or decreased blood volume, organ dysfunction and adverse outcomes can occur. Due to the decrease in blood volume, there is a decrease in vascular pressure to help perfuse the vital organs. This leaves them deprived of oxygen supply, which can cause immediate death. Conversely, if the patient is suffering episodes of hypervolemia or an excess of blood volume, organ dysfunction and adverse outcomes can also occur. In cases of fluid overload, the heart is stressed while pumping the extra volume through the circulatory system. This oxygen-depleted or diluted hemoglobin blood is insufficiently oxygenated to supply or sustain the life of these vital organs. If we look at the diagram to the left, it outlines how these vital organs are impacted by fluid overload. Cerebral edema can cause impaired cognition and delirium. Pulmonary edema can result in impaired gas exchange, reduced compliance, and increased work of breathing. Increases in renal venous pressure and renal interstitial edema impedes clearance of uremic toxins and can cause salt and water retention. Tissue edema can cause poor wound healing, infections, as well as pressure ulcerations. Gut edema often results in malabsorption of nutrients and can cause ileus. Impaired synthetic function and cholestasis are often associated with hepatic congestion. And myocardial edema is often associated with conduction disturbances, impaired contractility, and diastolic dysfunction. Oxygenation is also greatly impacted by fluid overload. When we review this slide, we can see there are several conditions that can cause a decrease in oxygenation. Impaired gas exchange due to hypoventilation can occur at the alveolar capillary bed. Patients who may be anemic due to fluid overload often fail to have sufficient red blood cells with oxygen-carrying capacity to deliver appropriate amounts of oxygen to the tissues. Circulatory function can be severely compromised due to hypervolemia, as the heart is overwhelmed and cannot pump with enough force to deliver the appropriate amount of blood to the organs. And as the metabolic processes are impeded, systemic inflammatory responses can lead to hypoxia. There are three very important measures of oxygen saturation used to monitor the cardiac respiratory system. Let's review each in some detail. Venous oxygen saturation, or SVO2, measures true mixed venous blood, that is, blood that is circulated through the superior and inferior vena cava, coronary sinuses, and all chambers of the right side of the heart. SVO2 may provide a more accurate picture of oxidative balance than mean arterial pressure, or MAP, and heart rate. Normal ranges vary from 60 to 80%. Central venous oxygen saturation, or SCVO2, is venous blood measured through a catheter placed in the right atrium of the heart returning from the upper half of the body. It is perhaps the best evidence-based parameter to manage oxygen delivery, DO2, and oxygen consumption, VO2, improvement. Normal ranges vary from 60 to 80%. Lastly, but equally as important, is arterial oxygen saturation, or SaO2. SaO2 measures the percentage of oxygen bound to hemoglobin. This provides the clinician with an accurate assessment of oxygenation status. Normal ranges vary from 90 to 100%. Let's take a few moments and discuss central venous oxygenation saturation in more detail. Many consider SCVO2 as one of the most important oxygenation measurements that is utilized in determining a course of action when treating the critically ill patient. SCVO2 can be quickly obtained by placing a catheter into the right side of the heart. This central venous catheter would be indicated if the patient is in complete kidney failure and requires CRRT or hemodialysis. Low levels of SCVO2 is associated with poor outcomes. Studies indicate that mortality increased by 4% with every 1% decrease in mean SCVO2. Sustained levels of SCVO2 will help provide the clinician with information on how well oxygen is being delivered throughout the body to its critical organs and how well the organ systems are consuming oxygen. Levels less than 65% may indicate ineffective oxygen delivery, and levels greater than 75% may indicate ineffective oxygenation consumption. Oxygen delivery and consumption are critical in maintaining organ viability, so immediate access to this information is extremely valuable. There are several factors that affect SCVO2. The red box to the left shows several examples of conditions that may result in increased SCVO2 due to a lower demand for oxygen. Increased hemoglobin levels, oxygen carrying capacity, and cardiac output can give the heart and critical organs the oxygenation necessary to produce enough energy to survive. For critically ill patients who may be under anesthesia, sedated, or hypothermic, metabolism slows greatly, decreasing the need for oxygen use. This may be the necessary course of treatment and sustainable for only short periods of time in a controlled setting. In this instance, an increase in SCVO2 percentages may present. The blue box to the right, however, presents a very different scenario. Patients who are experiencing symptoms of cardiogenic shock, low hemoglobin levels, hyperthermia, low SaO2, and perhaps shock will have an increased demand for oxygen. Due to the severity of the condition, decreased cardiac output will affect the body's ability to deliver oxygen-rich blood supply to critical organs. In these instances, we see decreased levels of SCVO2 as their DO2, oxygen delivery, will be much lower than the VO2, oxygen consumption. Let's review the different treatment options available in the acute setting. Intermittent hemodialysis, or IHD, is traditionally prescribed for 3 to 6 hours with frequencies ranging from daily and 3 times per week to every other day. This treatment allows higher blood and dialysate flow rates and associated solute clearance levels. Slow, low-efficiency dialysis or prolonged intermittent renal replacement therapy is traditionally prescribed for 8 to 12 hours per day. With lower blood and dialysate flow rates, this treatment yields gradual fluid and solute clearances, allowing excellent solute control. Studies have shown this therapy to be associated with less hemodynamic instability than IHD. Continuous renal replacement therapy, or CRRT, is traditionally prescribed for 24 hours per day of treatment in an ICU setting. CRRT provides slower but maximized solute clearances based on treatment length. Solute removal is achieved through convection, hemofiltration, diffusion, hemodialysis, or a combination, hemodiafiltration. Before we begin to review how to utilize CritLine technology with patients who are critically ill and require renal replacement therapy, let's review the CritLine technology available to support the various treatment modalities utilized in the acute setting. Fresenius Medical Care offers 2 devices for use during intermittent hemodialysis treatments: the 2008 T machine with integrated CritLine technology, or CLIC, and the CritLine 4 monitor, a standalone monitor. The Critline 4 monitor is also available for use during SLED and other prolonged intermittent renal replacement therapies, as well as CRRT treatments. Let's take a few moments and review the key Critline data points available throughout treatment and where to easily locate on either the Critline screen on the 2008T with Click or the Critline 4 monitor. Hematocrit, estimated hemoglobin, percentage change in blood volume, and oxygen saturation are displayed continuously throughout the treatment. This real-time data is invaluable as it will change as your patient's condition changes. This will allow the clinician to make quick and immediate decisions if the patient's condition changes, allowing for immediate intervention if necessary. With the display of the percentage of relative blood volume change and visual profiles to allow immediate access to treatment trends, Critline allows for the immediate analysis of the patient's intradialytic UF goal tolerance. Immediate access to data to support intervention, to avoid symptoms, or further challenge fluid removal goals provides key information. Patients with little or no change in relative blood volume reduction may be able to tolerate an increase in ultrafiltration rate if hemodynamically stable, while patients with a blood volume reduction of 6.5% or higher suggests that the rate of ultrafiltration is outpacing plasma refill rate and may benefit from a reduction in UF rate to avoid complications. Simply put, with Critline technology, clinicians have immediate awareness of any change in the patient's status. They can promptly detect the risk of adverse events and supporting the prioritization of patient care. As we have reviewed throughout this presentation, awareness of data relevant to blood volume and oxygenation status is valuable to the management of critically ill patients receiving renal replacement therapy. Let's take a few moments and review some key Critline data that is available for assessment. As we see the relative blood volume decrease and oxygen saturation levels increase, that data is suggestive of patient tolerance of the current ultrafiltration rate set, and may be relevant to whether the corresponding blood volume reduction is supporting improved oxygenation. Data showing the relative blood volume decreasing with no improved oxygen saturation levels may be relevant to the fact that the RBV reduction is not supporting improved oxygenation of the blood. Again, this data could be relevant to underlying lung damage or disease that is impeding the gas exchange, or a lack of hemoglobin to supply oxygen to meet organ demand. If the data showing the relative blood volume is decreasing and the oxygen saturation is decreasing, this may be relevant to a more serious or even urgent condition present. If presented with these data, oxygen decrease despite removing the excess fluid, immediate MD intervention may be required. With immediate access to both the percentage of blood volume change and oxygen, think of Critline as providing a window into the patient's vascular space. Thank you for taking the time to review this Critline training for the hospital-based setting on volume management of the critically ill patient receiving renal replacement therapy with data from the Critline monitor.